Hey everyone, welcome to this explainer. Today, we're totally unpacking the 2024 RCOG Green-top Guideline number 59, so you can absolutely crush your MRCOG exams. If you're prepping for the boards right now, you already know that staying up to date with the latest guidelines isn't just nice to have, it's absolutely essential. So we're going to break this massive document down into bite-sized, highly testable concepts and visually lock this stuff right into your memory. Let's get into it. But before we start, rote memorizing those specific evidence grades, ask yourself a critical clinical question to set the stage for your learning. Is your outpatient hysteroscopy practice actually up to the 2024 standards? It is so easy to fall back on historical habits or just what you might see every day on the ward, right? But the examiners, they are looking for your grasp of the current evidence-based gold standards. So let's make sure your knowledge lines up perfectly with what RCOG expects today. Okay, here's our roadmap. Let's map this guideline directly onto the chronological patient pathway to build a great mental scaffold for exam recall. We've got 1. Service provision requirements, 2. Patient information and consent, 3. Analgesia and cervical prep, 4. Equipment and procedural technique, and finally, 5. Post-procedure care. Starting off with Section 1, Service provision requirements. Let's look at the mandatory setup of a clinical service itself. We're pulling straight from the newly updated Green-top Guideline 59, published in the BJOG. Now, I want you to keep the overarching theme of this entire document in the back of your mind for literally every single exam question you see on this topic. Ready? Every single guideline and recommendation here is laser-focused on minimizing pain and optimizing the patient experience. Outpatient hysteroscopy is a game changer because it skips general anesthesia. But let's be real, it can cause some serious anxiety and discomfort for the patient. Every standard we're about to hit is designed to mitigate exactly that. So it might actually surprise you to learn that conducting the procedure in a formal operating theater is not a mandate. Actually, scratch that. Doing it outside a formal theater to reduce patient anxiety is considered a good practice point. However, providing a dedicated outpatient hysteroscopy service for abnormal bleeding and reproductive problems, that is a strict Grade A mandate. The data proves it provides quicker recovery and less time off work compared to general anesthesia. Also, you need a minimum of 2 support staff. Specifically, that's 1 registered nurse and 1 healthcare assistant to act as an advocate for the woman, and that's another good practice point. Knowing the difference between a strict, evidence-backed Grade A rule and a group practice point is exactly how examiners separate the good candidates from the great ones. Moving right along to Section 2. Patient information and consent. Let's look at how we prep and counsel the patient. You've got to know that providing written information is absolutely vital for informed consent. Prior to their appointment, patients need the full rundown: procedure details, benefits, and the risks. And yes, you must explicitly include the risk of pain. But pay close attention to this highly testable good practice point. Women must be made aware of alternative options for care, as well as other modes of anesthesia. We're talking general anesthesia, regional anesthesia, or IV sedation. You literally cannot just present the outpatient setting as their one and only option. The crucial takeaway here is prioritizing patient autonomy. It is an essential medical, legal, and clinical standard to stop the procedure immediately upon patient request. Period. If you get a clinical scenario in your exam where a patient looks to be in too much pain, or maybe she's having a vasovagal episode and can't even use her voice, the clinical team must alert the hysteroscopist, and you stop right there. There is no just pushing through under the 2024 standards. No way. Just like in your OSCEs, completing the pre-procedural safety checklist is a critical good practice point. You need 3 identifiers for the patient, you must document verbal and/or written consent, you've got to check their allergy status, and crucially, you absolutely must exclude pregnancy. A urinary pregnancy test should be done if the patient is premenopausal and sexually active. Now here's a very specific nuance. If she declines the test but states she is definitely not pregnant, the guideline specifically notes that her wishes should be respected if she wants to proceed. Keep that tucked away for a tricky multiple-choice question. Okay, on to Section 3, Analgesia and Cervical Prep. This builds our understanding of pharmacological interventions before we even touch an instrument. Burn this number into your memory: 1 hour. Look, we all know clinic timings rarely run perfectly in the real world, but for the exam, women must be advised to take standard doses of oral NSAIDs exactly 1 hour before their scheduled appointment. Why does the timing matter so much? Because it's backed by level 1++ evidence. It carries the absolute highest recommendation. NSAIDs are literally the only medication shown to reduce pain both during and after the procedure without jacking up the side effects.
Now, this is exactly where examiners love to test the nuances. Routine conscious sedation, Grade B, do not use it. Routine local anesthesia for a standard vaginoscopy, Grade A, do not use it. But And this is a big exception. If clinical indications demand a vaginal speculum, say you anticipate needing cervical dilation due to stenosis, or maybe you're using a larger hysteroscope with an outer diameter of 5 millimeters or more, then you absolutely should consider local anesthesia, and that also carries a grade A mandate. It's all about context here.
Keep this brief grade A recommendation in mind as well. Despite the old school practices where prostaglandins were handed out left and right to soften the cervix, routine cervical preparation is no longer the standard. Sure, it can reduce pain a bit, but it just brings along genital tract bleeding, abdominal cramping, and gastrointestinal side effects, all without actually dropping the risk of a uterine perforation or surgical failure. So, we drop it. All right, Section 4, Equipment and Procedural Technique. We're stepping into the procedure room to review the strictly graded technical approaches.
This right here is a classic exam contrast. It solidifies vaginoscopy as the undisputed grade A gold standard over the traditional speculum approach. The vaginoscopic no-touch technique massively minimizes the pain and embarrassment that comes with speculum insertion and cervical grasping. Like we just covered, the speculum is now the exception. You reserve it only for when you specifically need to administer local anesthesia or dilate the cervix. Here's another absolute must-know metric: 3.5 millimeters. Every fraction of a millimeter matters here. Hysteroscopes used for diagnostic procedures must be 3.5 millimeters or less in outer diameter. Meta-analyses consistently show that these miniature endoscopes significantly reduce the pain the woman experiences. It's a total game changer.
So, what happens when we switch gears from diagnostic to operative? Well, the evidence is incredibly strong here. Mechanical tissue removal systems decisively earn a strict grade A mandate over miniature bipolar electrodes when you're removing endometrial polyps. The data proves mechanical systems aren't just quicker and more successful, they are definitively less painful and way more acceptable to the patient in an outpatient setting. And always remember, minimizing intrauterine pressure is not just common sense. It is a formalized grade A standard of care. High pressure equals high pain. You must instill the sealing distension medium at the lowest possible pressure needed to still get a satisfactory view of the cavity. The entire goal is to keep the patient comfortable while maintaining your diagnostic accuracy.
Okay, final stretch. Section 5, Post-Procedure Care. Let's wrap up the patient pathway. Once the procedure is done, clear communication in a comfortable setting forms the final good practice points you're going to be tested on. Please, do not give the patient complex clinical news while she's still lying there half-dressed on the examination couch. Let her get changed, bring her to a comfortable, private area, and then empathetically talk through the findings and the next steps. Plus, you have to provide a written summary directly to the woman and ensure a written summary gets sent to her GP. Departments also have to audit specific metrics for quality and safety. And let me tell you, these numbers are absolutely ripe for exam questions. The threshold for providing that written information pre-appointment, it has to be 95% or higher. And keep a close eye on these pain scores. Peak interprocedural pain should average 5.2 or less on an 11-point visual analog scale for diagnostic procedures. For a hysteroscopic polypectomy, that target is 5.1 or less. If an audit shows a clinic's average is creeping above these numbers, their pain management protocols need an immediate overhaul. So, as you buckle down for your MRCOG exams, think about how mastering these exact evidence grades will actually transform your daily clinical practice and improve patient outcomes. We've seen how the 2024 Green-top Guideline radically shifts the focus toward patient autonomy, hyper-strict pain management, and using specialized equipment like does 3.5 millimeter scopes. Don't just memorize this stuff for the test. Ask yourself, how will you adapt your daily clinic to empower patients and meet these grade A standards? Thanks so much for hanging out with me in this explainer. Keep reviewing these concepts, trust the evidence, and best of luck crushing that exam.